The clinical and pathological manifestations stem from the inflammatory response surrounding viable, dead, or decaying sand fleas. This response triggers acute inflammation characterized by erythema, edema, pain, and itching, attributed to the presence of a biologically active foreign body within the epidermis. This body exerts pressure on surrounding tissues. The inflammatory response intensifies with bacterial superinfection, a common occurrence in endemic areas where aerobic and anaerobic bacteria, including Clostridia, have been found in embedded sand fleas. It's reasonable to assume these bacteria may initially adhere to adult fleas from the ground, later carried into a host's epidermis. Moreover, scratching can introduce pathogens underneath the skin. Another inflammatory pathway links to the presence of Wolbachia bacteria in burrowed sand fleas. When these parasites die in situ, the release of Wolbachia-derived lipopolysaccharides triggers an inflammatory response in the surrounding tissue. In regions with low tetanus vaccination coverage, there's evidence suggesting a potential link between Tungiasis and tetanus. This association isn't surprising, considering Clostridium tetani, the tetanus-causing bacteria, is a soil pathogen. Adult sand fleas might passively carry bacterial spores into human skin, or scratching lesions with soil-contaminated fingers could introduce the pathogen. These diverse pathophysiological mechanisms can result in suppuration, abscess formation, ulcers, lymphangitis, tissue necrosis, and gangrene. Consequently, chronic pain, disability, and disfigurement occur, leading to the distinctive gait seen in individuals from endemic areas. In Brazil, heavily infected children were observed to experience walking difficulties. Affected children often exhibit high absenteeism and perform poorly in school due to constant itching and pain, impacting concentration. These chronic effects are debilitating. Foot disfigurement and mutilation impair mobility, hinder daily activities, and affect household economics, heavily reliant on the physical fitness of adult household members. The pathogenesis of chronic Tungiasis manifestations like desquamation, hyperkeratosis, fissures and ulcers, nail rim hypertrophy, toe deformities, and nail loss remains poorly understood. Desperate individuals resort to using unsterilized sharp instruments like safety pins, needles, and knives to remove parasites, which often causes bleeding. This traditional approach might inadvertently transmit bloodborne pathogens like hepatitis B and C viruses, and potentially HIV, among household members and neighbors. The high prevalence of hepatitis B in sub-Saharan African children could, theoretically, partly be linked to this traditional Tungiasis treatment. Severely inflamed toes and mutilated feet aren't easily concealed, leading to feelings of shame among those affected, as seen in other parasitic skin diseases with similarly inflamed skin. Children with Tungiasis face teasing and ridicule in rural Kenya, and patients in Brazil and Nigeria suffer social stigmatization. Please remember to subscribe to our channel, click the like button, and activate the notification bell if you wish to see more content like this. Thanks for watching.